I'm quite unique in terms of being a nursing professor. The nurses and non-academics in the audience probably don't know that there are very few nurse academics who still remain in clinical practice for all sorts of historical reasons, and I'm not going to go into the history of that today. So it's thanks to the Florence Nightingale Foundation that we have quite a unique role here at Glasgow, in the fact that although I'm employed by the university, I'm 50% in NHS. So it does feel like two jobs, two bosses who are fantastic, but it does feel like more than two jobs. This is very weird for me because this is probably the first time in my life I've had colleagues, friends, and my family in the audience. So you are going to get a story, biography, if you like, of a little bit about me before I talk a little bit more about the topic and my speciality. But I will talk about why I decided and why I became a nurse, as well as why I got interested in this topic as a speciality. I was born in Blackheath in South London, but my parents moved when I was 2 months old, my poor mother, and with my older brother Nico to Hereford when my father became canon of Hereford Cathedral, and this was our house. So we grew up in fantastic houses. Jo, my sister, is a photographer, and she'll probably wonder why I chose the black and white photograph of our house in Hereford, but probably that's how I remember most photographs of the time that we lived there in the 60s and 70s. Our house in Hereford was particularly beautiful. We didn't know anything else, but growing up the side of the house, you can probably just about see in the black and white picture, was beautiful wisteria. And when we were small children, we didn't understand why people would want to photograph the front of our house, but it was because of the beautiful wisteria growing up. We lived in Hereford for 13 years, and then we moved to Southall in Nottinghamshire when my father became provost, which is dean. People here probably don't understand Church of England hierarchy, but my father was dean of the Cathedral Church in Nottinghamshire when we moved to Nottingham. And there we stayed until the early 1990s when my parents retired. This is us as a family. When we were small children, we used to tease my father that he actually only knew our ages when we were 3, 6, 9, 12. So I think that's just about the ages we are in this picture. I've worked in end-of-life care long enough to know that we rarely speak ill of the dead, but we really, truly, that's a more recent photograph of me with my siblings, but we rarely speak ill of the dead, but our parents really were wonderful people. That's a picture of them probably taken. Jo will probably tell me exactly when that was taken, but it was probably early, sort of end of the 80s, I think, probably that picture. Our father, it's really difficult to sum up my father just in a couple of sentences. My dad was classically educated. He read classics at Cambridge. He was always a very clever person, and I told my children when they were really small that they probably would never in their life meet such a clever person as their papa. And I think that is probably true. He always, even in the last year of his life, he had about 4 or 5 books on the go. But he also had the most tremendous sense of humour, and he had a limerick for every occasion. So all through our childhood, we always had a limerick for anything that was going on. He also was probably, he had the encyclopedic knowledge of Shakespeare, which I always found quite good fun when I was doing English A-level. But he also could be a very irreverent reverend and had a most wicked sense of humour. This is just a picture of my father in the last year of his life with my children. You can see that the year that my father died, Murray and Flora were only 4 and 7. And we had a fairly classic funeral for my dad, but we also had a memorial service. And I thought that's a really quite hard concept to explain to a 4-year-old. So as best I did, I explained what we were going to be doing when we were burying my father's ashes. But after the service, I said to Flora, what did you understand by what happened? And she said, oh, they cut Papa up chopped him up into lots of little pieces. They stuffed him in the sweetie jar, and then we buried it. And I thought, that's sort of, as a palliative care nurse, so I thought I explained things well. Clearly, I hadn't explained cremation very well to a 4-year-old. Our mother. So our mother is, if you sort of were doing your mathematics, you will see that our mother died far too young. She was an amazing mother for, truly wonderful person, beautiful inside and out. And she had those sort of qualities that we rarely revere today. She excelled at being a friend, sister, wife, and above all, mother. But actually, it wasn't because of my parents that I chose to be a nurse. It was Auntie Margaret. My aunt was a midwife, and she was a nurse first and then a midwife, as you were in those days. And she, her last job before she retired was a similar job to Mag's, although that was in the 80s. So they, in sort of health services reform all the time. So she was what was called then a chief administrative nursing officer for South Glamorgan. But she actually got her damehood for being president of the Royal College of Midwives. But Auntie Margaret she never had children herself, and she was very fond, particularly of all her nieces and nephews, but I think particularly us, because she was so fond of my mother. And it was really through Auntie Margaret and her inspiration and talking to her that I decided that I wanted to be a nurse. And I probably wanted to be a nurse from primary school. I was talking to one of our undergraduates this week, Eleanor's in the back row, about when people decide to be a nurse. And I don't think there's so many people now today who know that they want to be a nurse from when they're small children, but I did. I trained at St Bartholomew's Hospital in London, as you can spot me in the back row there. It was excellent teaching, excellent training at a typical London teaching. Actually, Barts isn't typical, but typical for the day in terms of a London teaching hospital training. And you can see me a picture of me now at my graduation. The nurses here in the 1980s, if you graduated from a London teaching hospital, you graduated in uniform, so full uniform with full linen apron there and hat, which I never managed to make the whole 4 years I was at Barts. We used to make them around petticoat tail shortbread tins. But you also got your certificate from a royal. That's the Duchess of Gloucester there. But I knew really towards the end of my time at Barts that if I wanted to go into nurse education, which was the area that I was became interested in, that I needed to do a degree. So I stayed at Barts. I worked for a year at Barts on Dalziel ward, which was a medical oncology ward specialising in leukemia. Interesting that one of my old PhD students is here, did a PhD around acute leukemia. So it was great fun learning about leukemia again when I was supervising Constantina. Actually, for those, I don't know if there's anyone here from our Institute of Cancer Sciences, but our head of our Institute of Cancer Sciences, Professor Jeff Evans, was a junior doctor on Dalziel at the same time as me. And then, so I went to Cardiff University after a year working at Barts. Between leaving Barts and going to Cardiff, I worked in a children's summer camp in America. And when I got back from America, it was only about 2 weeks before I started at Cardiff. So I went to stay with Auntie Margaret, who was living in Cardiff at the time, and ended up staying there for the whole 3 years. This is another photograph of my sort of last year time at Barts. So these were my 3 flatmates, who were my whole flatmates for my whole time at Barts. So Claire, who unfortunately couldn't be here today, was in the dark hair next to Julia, who's wearing the cape. Amanda's at the end. Claire's still my best friend now. I was on holiday in Arran with her 2 weeks ago, and she's godmother to my eldest, Murray. We actually have quite an incestuous relationship, the 4 of us, because Amanda married Claire's brother, Julia married Martin's best friend, and I met my husband, Craig, at Claire's wedding. Neil, Claire's husband, was at school in Jordan Hill with Craig, so and we're quite an incestuous group of 4. One of the things it's not peculiar to nursing, but I think is particularly important in nursing, is the concept of mentorship, and particularly around role modelling. I'm going to pick on 4 people today who've mentored me throughout my career. There's been many more, but I've just chosen to pick on 4. And the first one is Jo Hockley. So some people in palliative care will have heard of Jo, but I knew Jo when I was a young, naive student nurse. Jo ran the first ever nurse-led hospital symptom control team at Barts. The history will say there was one at St Thomas's, but Barts and St Thomas's were always rivals. But that was the St Thomas's team was led by a medic. So Jo was the first hospital symptom control team, was the model for our modern hospital palliative care teams today. And Jo was just fabulous at just sort of light touch teaching, really, informal role modelling. And I learnt so much, particularly that how care of the dying actually could be a speciality and how we could actually do it well. Because on Dalziel Ward, most of our patients in those days, if you didn't die of leukemia, you died of the treatment for leukemia. So many of our patients did die, but they were the same age of the nurses working on the ward. So we weren't always very good at care of the dying. So it gave me great inspiration seeing how Jo, dealt with patients, cared for patients with such fabulous compassion. But as I said, I went to university in Cardiff. My daughter will be pleased with the different hairstyles over the ages. Bit frizzy there, right? Cardiff, the School of Nursing at Cardiff was in the University of Wales College of Medicine. We were based up at the Heath Hospital in Cardiff, and it was a fantastic degree. The sort of nursing degrees in the 80s were quite different to now. There were very few nurses doing degrees, and my course was quite unique because there were 12 of us, and we were all qualified nurses. And our Dean of Nursing at the time, Chris Chapman, is one of the sort of well-known names of early academic nursing. And Chris said to us, the 12 of us, that, we were all young, we were all sort of early 20s, we were all being qualified very short period of time. But Chris would say to us that you are going to be the nurses of the future, and you're going to go in probably one of three directions, either advanced nursing, practice, and there was really no such thing as that really then, but she had a great vision for that, or in education or management. And she encouraged us, whilst we were doing the degree, to look at doing skills and qualifications in the areas that we were going to go alongside our degree. So I took her at her word, and my second year I did a further education teaching certificate, and in the final year of my degree I did my postgraduate certificate in education alongside my degree. So when I graduated from Cardiff, I graduated with a teaching qualification as well, and I moved to North London, and it was Barnet and Edgware Hospital's College of Nursing at the time had a great new vision, because the new Project 2000, new diploma in higher education, was coming in, and they really wanted to have nurse educators who were young, bright, with degrees, who would work alongside people in practice. It was a fantastic job. I absolutely loved that job. It was particularly sociable. So for a single woman in her early 20s, it was a particularly social job. And I saw a lot of my sister Claire, who's in the front row during that time. We used to meet at the other end. We lived on other ends of the Northern Line at that time. So we used to meet in the centre of London. Claire was always late. No such thing as mobile phones, so often waiting at tube stations for my darling sister. So after working for 2 years in Barnet and Edgware, I really decided that this thing that was by then being known as palliative care might be a speciality that I might be interested. Whilst I was doing my degree in Cardiff, it was the first time that I got an opportunity to work in a hospice. And there was great advantage to having the university holidays, because I worked for 3 months in a very small hospice in Surrey called St Raphael's in North Cheam. And it was the most fantastic time, because I knew I was only there for 3 months, so I gave loads. And as nurses, sometimes we hold back, but I didn't hold back. So I gained loads and just fantastic amount, really learning from patients more than anybody else. But it was long before the modern palliative medicine. And we had 10 beds at this hospice. And our medic was a lady called Juliet Boyd, who was actually an anaesthetist, a consultant anaesthetist by day, used to pop in at the end of her shift. So that was our medical input. She was fantastic, Juliet, but not like my colleagues who are here in the audience who've done palliative medicine training. So I knew that this was a speciality that I wanted to go in. And Macmillan at the time, Macmillan Cancer Support, the charity, had really started up a new initiative. So Macmillan nurses had been going for a while, but they decided to employ what they called originally Macmillan tutors and then Macmillan nurse teachers to be based in colleges of nursing to really train the new generation in terms of palliative and end-of-life care. So I was fortunate to get a job in Cambridge This would have been 1993. I was the second wave ever of this job. So I was one of the youngest people doing this job in my 20s. But it was fantastic. So I was employed by Cambridgeshire College of Health Studies, it was called then. And I was based in Homerton Hospital in Huntingdon, and covered a large area. So my main job was running a course, an English course called the EMB 931, Care of the Dying course, and the EMB 285, which was the Early Nurse Palliative Care course. So my job was really running these courses for all sorts of nurses across Cambridgeshire. And I also worked in practice. So my job covered 2 hospices. So Arthur Rank in Cambridge and Thorpe Hall in Peterborough. Fantastic job. My job was just teaching end-of-life care and palliative care. So a lot of the other nurse teachers were very jealous because they were doing lots of bits of everything from blood pressures one day through to whatever the next day. And I was only doing palliative and end-of-life care. But when I was in Cambridge, that was when I met my husband, Craig. And I thought Cambridge was a bit too English for a Scotsman to come and live. So I moved up to Scotland and got a job at Strathcarron Hospice as a lecturer in palliative care, where I stayed for 11 years. My second mentor, Jean, was the most fantastic colleague, just brilliant. She taught me so much, and not just about nurse education, hospice care, working like manic hours. Jean did sometimes. She would do that thing. She would say to me, can you read this paper and comment on it in the morning? And it would be like, 5 o'clock or 6 o'clock at night or something. But she was the most fantastic educationalist, Jean. And I think ahead of her time in so many ways, because Jean felt that fundamentally the most important thing in hospice care, palliative care, and end-of-life care was communication. And Jean was really taught communication skills. She sort of revolutionised education and training in communication skills in Scotland. But Jean also, her vision was ahead of her time, because she set up, and the reason I was employed was to run a postgraduate diploma in palliative nursing, which was between Strathcarron and here at the University of Glasgow. So it was I still think that that's probably the best ever course in palliative care, certainly in the UK, having been involved in education for a long time. It was a lot of face-to-face teaching, and actually, in fact, most teaching, the educators will know now, is often online, and there's a lot of palliative and end-of-life care that needs to be taught face-to-face. And Jean would not have coped with modern education, because she absolutely believed in honing your skills and knowledge, and being appropriately taught and mentored through that. Whilst I was at Strathcarron, I was there for 11 years. I did my PhD here at the University of Glasgow and had both my children. So I did that crazy thing. I've got some of my brand new PhD students in the audience. I did a PhD the crazy way, because I was working full time, and then I had the children. Well, I had Murray in the middle, and then I was pregnant with Flora at my viva. And actually, PhDs with small children don't mix particularly well. When I was back at work at Strathcarron, I worked 2.5 days a week. And on Saturday mornings, Craig used to take a very tiny Murray, swimming or round the park, and often round Kelvin Grove Art Gallery. So Murray, when he was really very, very small, knew the names of a lot of the exhibits at Kelvin Grove Art Gallery. So he would talk about tapirs when he was about 2. I think it was a dugong as well, as one of your favourites. He won't remember this because he was not even, he was about 2. That's the picture of my graduation here at the university. So tiny Flora by then. And Murray wondering what on earth was happening. Age 3 in a kilt at my graduation. I think you were very, very confused by that. So we're going to move on to the topic in hand in terms of end-of-life care. This is an infographic from the BBC. So, how many people here today do actually think about death and dying? Probably very few. I'm probably strange because I do think about it a lot, but then that is my speciality. So and there are other people here who work in palliative and end of life care, and they will. But how many actually have told somebody about their funeral wishes? Again, probably that this room will probably be slightly higher than the percentages, the stats for the UK as a whole. Again, with have you written your will? Have you registered as an organ donor? And more importantly, such a small percentage of us think about our future care. Right, we're going to look at something just a little bit different, so I hope this is going to work now. Some people have seen this before, and I'll explain why we're looking at this.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. But it's not right, because this ain't the way to die. This ain't the way to die.
I can't tell you what I really want. You can only guess what it feels like. And right now it's a steel knife in my windpipe. I can't breathe, but you still fight, cause you can fight. Long as the wrong's done right, protocol's tight. High off of drugs, try to sedate. I'm like a pin cushion, I hate it. The more I suffer, I suffocate. Right before I'm about to die, you resuscitate me. You think you've saved me, and I hate it. Wait, let me go, I'm leaving you. No, I ain't. Tube is out, you put it right back. Here we go again. It's so insane, cause though you think it's good, I'm so in pain. I'm more machine than man now, I'm Anna Kane. And no advance directive, I feel so ashamed. And crap, who's that nurse? I don't even know a name. You lay hands on me to prolong my life again. I guess that you must think that this is living.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. It's my right to choose the way that I should die. The way that I should die.
Z-Dog MD.
The way that I should die.
This ain't easy. Get the family. You ever love somebody so much you can barely see when you with them, that they lay sick and dying, but you just don't wanna let them be at peace, cause you miss them already, but they ain't gone. Beep beep, the ventilator alarms. I swore I'd never harm them, never do nothing to hurt them. Hippocratic oath, premium, not no, so right now I'm forced just to torture them. They push full code, no one knows what his wishes were. His sister heard him say once, I don't wanna be a vegetable. But no one agrees in the family. The caregiver Kate wants some comfort care, but Aunt Claire lives so far away that her guilt eats her like a cancer, so she answers, wait, I think he'll wake. Ma'am, you ain't even in the state. Palliate, relieve pain, get him home, explain. Critical care, just hypocritical when it's so insane. But they insist I shock his heart against a persist. I guess that's why they say that love is pain.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. It's my right to choose the way that I should die. The way that I should die. The way that I should die.
I chose that for various reasons. I'm particularly interested in the role of social media in end-of-life care, and that's the most watched and anything to do with end-of-life care on YouTube. But also, if you did actually listen to the words, I think they're very relevant for what we're talking about today in terms of, do we really think about end-of-life care? Whose responsibility is it? And what our role as nurses is, and in particularly in terms of end-of-life care. Since I'm an academic and we're also talking about my research, these are just some example of some of the people who have funded my research. Our speciality, funding any research is really tricky nowadays, and particularly in the current climate. But I think my speciality is one of the ones that's just it is particularly hard to fund and to find funding for all sorts of reasons. And some of those might be political reasons as well as anything else. But I've had a whole variety of funders. I wouldn't have got to be a professor if I hadn't done funded research. I have worked particularly with clinical partners across Scotland, but also the rest of the UK as well. So probably some of those unusual funders in there. Karolinska Institute in Sweden. I had a postdoc Swedish nurse worked with me for 2 years on a special postdoc fellowship. FIPSI is actually US government. I did a very unusual project, which was a joint EU-US government funded project around self-management and palliative care that was mainly about partnership. What the US government and the EU wanted was to see academics working together. We were the only nurses, the group that I worked with. It was Scotland, New York, Chicago, and Lithuania. So I think we probably got the grant because of an unusual combination of people. And my research has fundamentally, obviously, it's mainly around palliative and end-of-life care, but centred on particularly around self-care and self-management, which we're going to talk about evaluating, developing and testing healthcare interventions. A key area, which is part of my job here at Glasgow, which I'm particularly interested in, is about building research capacity. And when I talk about one of my other mentors, I have learnt loads from this person about building research capacity. But more recently, the area that I'm focusing on is dignity and end-of-life care. And I will talk a little bit about that here today. The themes that run through my research are mainly around patient experience and also around self-management. So I posed the title of End-of-Life Care, Whose Responsibility? So not surprisingly, I'm going to talk about the nurse. And a good academic goes to the Ladybird Book of the Nurse. But most people who've been into my office will know that I've got a poster of this on my wall. And it's quite funny reading the Ladybird book. We won't do that today. We just thought that's... But actually, one of the first nurse academics to talk about end-of-life care was an American nurse called Jean Quint, latterly known as Jean Quint Bolonial. Many people here will have heard of the work of Glaser and Strauss around communication and end-of-life care. And Jean Quint worked with Glaser and Strauss in that original study in the 1960s in San Francisco and did an amazing piece of work. If you can still get hold of that, particularly nurses who are interested in this area and interested in academic, it's worth reading Jean Quint's book because it's just amazing and still so relevant. 1967, she published that book, but still so amazingly relevant today. We've got to have a quote from Florence Nightingale. So Florence Nightingale, one of the founders of modern nursing, probably the most influential founders of modern nursing, said that nursing's an art. And if it's to be made an art, it requires an exclusive devotion, as hard as preparation as a painter's or sculptor's work. For what's the having to do with a dead canvas or dead marble compared with having to do with a living body, the temple of God's Spirit? It is one of the fine arts. I've always said the finest of fine arts. And so should nursing be the finest of fine arts. Actually, few people, considering that palliative care has been around. My colleague David, who's going to speak at the end, is an expert on the history of palliative medicine and palliative care. But considering we have had palliative care around for about 20 years, am I right, David? Now, few people have actually preferred a definition of palliative nursing, and I'm one of those people who's perhaps been brave or mad enough to do that. This is my definition. All life-threatening illnesses have implications for physical, social, psychological and spiritual health for both individuals and their family. And the role of palliative nursing is to assess needs in each of these areas, plan, implement and evaluate appropriate interventions. Palliative nursing aims to improve the person's quality of life and enable a dignified death. And that the palliative nurse enters into a unique therapeutic relationship with the patient, which demands competence in communication skills and emphasises role aspects such as educator, information giver, and highlights their key involvement in the delivery of individualised holistic care. One of the things that I've done is when I explored the concept of palliative nursing in more depth, I did what's called a concept analysis. So it's a type of literature review, but looking at that concept in more depth. So here's just some attributes of the palliative nurse from that concept analysis. So being a supportive role, an intensive caring role about fostering hope, providing comfort, providing an empathic relationship, being there and spending time with the person, also acting on the patient's behalf. And I think most nurses working in palliative care would emphasise the important role of teamwork. Knowing the patient is also a key part of this role. Some people would dispute that. I would still argue that, and certainly the evidence tells us that the role of dignity, a fundamental part of the nurse's role, and we'll look at this in a little bit more depth in a moment, is this need to be able to, willing to listen. Also helps if nurses know what they're doing. This is the model from my own PhD. My own PhD looked at the role of the palliative nurse from both the nurse and patient point of view. And one of the things, we did a mixed method study, or I did a mixed method study. But one of the things that we came up with at the end of the PhD was this model of the expert palliative care nurse. And the key thing that I'd like to talk about or home in on is what I called in my PhD personal or humane characteristics, and also this absolute importance of good communication skills. And it was great fun going back to my PhD, bearing in mind I got my PhD when Flora was a baby, that more than 15, 16 years ago. Flora was 16, so it must have been 16 years ago. Going back to that data was actually really good fun. This is a questionnaire that a master's student of mine has developed. So it's a sort of early stage of a measure to test how good Macmillan nurses are, using my expert nurse model as her framework. So exciting work. We need to do more work to validate that outcome measure, but great sort of ideas for the future in terms of a way of testing the effectiveness of the nurse specialist in palliative care. So this is some data actually from my PhD. So this is from a patient. I can still remember this patient distinctly today, and I can actually remember sitting on this man's bed in the hospice and talking to him. And this is part of what he said to me. An expert palliative nurse is one that can sit down and talk to you, hold your hand, and give you a wee bit of confidence. Someone like that cancer nurse who spoke to me in the hospital. I mean, she was really good, but that's her job, I suppose. A listener, and someone who will listen to you and doesn't talk. You want to talk to somebody, and you don't want to have to listen to them. And this from another patient. I think a good nurse in the hospice is a nurse who listens more than anything else. She listens with perceptive ears and with thinking and with her mind. She's not just hearing words, she's hearing emotions. She's hearing the things that are not being said. Think about that and think about how important that is. This is some data from some of the nurses I spoke to. The one thing that epitomizes effective palliative care for me is there's so much technology around now, but at the end of the day, it's the right kind of pillow or the right kind of bed that really counts. It's the small things when you're in hospital that really bug you, that you remember, that you get out of all perspective. And then another nurse. You need to put time aside so that patients get a chance to air any problems that they have, no matter how rushed you are. Sometimes they're frightened to say anything because they see you're busy. It's interesting that the concept of the busy nurse, actually there's another sort of well-known nurse academic who's supposed to have retired, but Ursula's telling me she's now on our board of trustees at the Florence Nightingale Foundation, Dame Professor Jill MacLeod-Clark. And Jill MacLeod-Clark's research really, I was so interested in when I read her research when I was a mere student nurse, because she talked about how we cannot communicate when we're busy. And she would talk about avoidance tactics that nurses use in their care. And she talked about something which I have definitely seen, and I'm sure the other nurses in the room have, which she called busy gate. So don't talk to me. I'm far too busy. What about that poor patient who needs to talk? Sometimes care can go wrong, and this is the sort of effect it can have on a nurse. This was a nurse who was a nurse specialist at the time. The patient's pain was very badly managed. It wasn't badly managed from the point of view that we weren't trying. We did try. We had actually asked advice. She actually died in agony. We all felt, we had failed her in some way. And this is from a patient who had a chronic respiratory illness, who I interviewed in a hospital in Scotland. And she says to me, I was in ward, and she tells me the ward, a year past January. I was very bad with asthma. Anyway, I lay there for 3 days without a wash, without getting my nightie changed. She had me crying, the ward nurse. I could not even feed myself. I could not hold a glass in my hand. Nobody came in to give me a hand. Nobody helped me. And that's when our wards were better staffed than they are now. So a little bit of a political bit here. Constantly in the UK, we have supposedly the best health service in the world. But if we want to make cost cuts, we cut the nursing budget. Easiest budget to cut, I suppose, because we have so many nurses in comparison to other health professionals in hospital. Here across Greater Glasgow and Clyde, we have over 15,000 registered nurses. But some of the best nursing research in the world talks about the need for minimum staffing for both your safety and quality of care. And if you go into hospital today, particularly with any illness that needs a great deal of care, if there aren't enough nurses on duty, that's the highest indicator for your mortality. This is just some summation of some of that best evidence from around the world. So evidence from large observational international studies, and that's all over the world now, this work, of good quality, have shown that hospitals with a higher nurse staffing have lower rates of mortality. We have very strong evidence to show that lower hospital use in terms of length of stay and readmission is associated with higher nurse staffing. We also have strong evidence, which is good for us as a university, is that nurses with a bachelor's degree significantly affects safety outcomes. There's also numerous other things about nurse staffing related to things like hospital-acquired infection and falls in hospitals. But that's just a wee summary. So how many nurses are on duty absolutely will affect your care in hospital. One of the things that I think we need to think about more in terms of the nurse's role in end-of-life care is the nurse's role in supported self-management. My own postdoctoral research, I did a funded postdoctoral study. I was funded by Medical Research Scotland, and I was the first time they'd ever funded a nurse. They normally fund clever medics and other scientists who are doing clinical science. So when I used to present at their open days, there were people talking about slices of rat, and then I would be talking about end-of-life care. Although I had the best questions I've ever had at those sort of days. But they had, luckily for me, that somebody had left them some money in her will. They'd left money to this particular organisation, and they'd said they wanted to go to a nurse or an allied health professional. And she left enough money for my study, which was 2 full years. And then there was a subsequent study where they funded a clinical psychologist. So now they don't fund nurses, but it's quite funny if you look at their statistics because they look a bit skewed because of my work. So just going back to the concept analysis, this is taking data, looking again about the role of the nurse in end-of-life care and looking at some of the attributes that we need to do to care for the dying better and what the nurse's role is in that. And we'll come back to this because on a fundamental important role in terms of self-management from the patient's point of view is the importance of maintaining normality. And I think we could do a lot more as nurses to help the patient to maintain normality. We're still afraid in the 21st century about helping people prepare for death. And that's just about being really good at communication. We have lots of initiatives around advanced care planning, but we're still really, really poor at going alongside somebody and talking to them about their impending death. I'm not expecting you to look at all the detail on this slide, but I just want to say about recent work that's been done by universities in Leeds and Southampton. So this was a large study around self-care for people, self-care around pain at the end of life in particular, led by Professor Mike Bennett, who's a professor of palliative medicine in Leeds, and Professor Alison Richardson, who's a professor of nursing in the University of Southampton. And for part of their work, they took the model that I developed and what I said around the nurse's role in self-care and took it further. Really nice. It's lovely as an academic to see how people can extend that work further. And that work has just recently been published in the International Journal of Nursing Studies by Natasha Campling, who was the researcher on that study. So this is a bit of data from their study. So this is a nurse and a nurse specialist. I have very clear memories of a lady being very competent and able with her medication. And then her disease progressed. And I arrived one day to say she'd put all her tablets onto a tray and mixed them. They looked like dolly mixtures. Because her condition had deteriorated so badly, and because she took the wrong medications at the wrong time, it exacerbated her condition. So it's that fine balance of monitoring, empowering people, giving them the information, but actually responding very quickly when you see that things have changed and their abilities have changed. And this can be so with a carer, because carers' conditions don't remain static. So I think that's a brilliant example of what the nurse can do to both support the person to look after themselves, but step in when they need to. This is the model that Campling and the team developed, taking my work further. So what they're saying is that the continuum of self-management behaviours goes from no engagement by the patient through to full engagement. And partly that will be influenced by the person's condition, but not just. I think we think it is, but it's absolutely not just influenced. They found in terms of pain medication at the end of life that the opioid-related factors, so the actual drugs, the strong drugs that the patients were having, their fears of opioids stopped their ability to self-manage sometimes. And the fear isn't just from the patient and the family member. That fear can be from the health professionals as well, but also influenced by the self-management roles that can be undertaken by the patient, the carer, and the nurse specialist. On to mentor number 3, Professor Harvey Chochnov. Harvey is a professor of palliative medicine in Winnipeg in Canada. He's a psychiatrist by background. He's a Canada Research Chair, and the North Americans like to grandiose their titles, and he's called a distinguished professor. Harvey is very well known in the palliative care world, and I came across his work towards the end of my postdoc, and I was particularly struck by some of what Harvey was writing. And I got the opportunity when I was working at the University of Stirling doing my postdoc. I won or was awarded a grant from a knowledge exchange, a knowledge transfer grant to go to Canada. I have travelled since my children were small, but my rule's always been never be away for more than 6 days. And my opportunity to go to Canada was for 3 weeks or a month. So we went as a family. The kids and Craig had a fantastic holiday. They were 8 and 11. Craig managed to get time off work. He was working in industry at the time. And I had the most fantastic time because I was able to work and concentrate. My family were there. And actually, when I was looking for photographs, my Murray, age 11, had the best photo album of the trip. You even had a picture of the place where we stayed. Holiday Towers, it was called. And we stayed on the 11th floor, but Craig and the kids discovered that they could get over to the Holiday Inn hotel by across a bridge, and they went swimming every day in the hotel. So The very bad selfie. Flora won't like my selfie of myself and Harvey there. But that's a picture of Harvey with his family and mine. So we became friends, and when your mentors or your friends, that the their mentor ability, I suppose, is enriched. And that's Harvey with his wife, Michelle, daughters, Lauren and Rachel, and the four of us. We had a fantastic time in Winnipeg. I spent time with Harvey, sort of learning about his research, learning about what he was doing. I also spent time with the palliative care team across the whole of Manitoba. And when Flora was teasing me one day that there was a Winnipeg festival on at the time that we were there. So Craig and the kids had gone to lots of different sorts of comedy. So Flora was saying, "Oh, you missed so-and-so." So I said, "Well, I saw a dead body and you didn't." So... Don't think you were that impressed, were you? But yes, so I did some clinical care as well. But it was the most fantastic time. And one of the interventions that I'm going to talk about that I've developed and are probably most well known for came from that stay with Harvey in Winnipeg. So this is Harvey's model of dignity, and this is what really touched me when I first read it. Harvey first published his model of dignity in 2002, and then with a further publication in 2004. And it was based on interviews that he and his team did with people who were dying in Canada, but also Perth, Australia, because Harvey had contacts in Perth, Australia. He also had done time working in Memorial Sloan Kettering in New York, so he has lots of data from both Canada, New York and Australia. So down the left, my left side, we have illness-related concerns. In the middle, we've got what Harvey called dignity-conserving repertoire. And on the end, he has what he's called social dignity inventory. And I think there's many things here that I find really, really interesting in terms of end-of-life care that we don't always recognise and do well. And one of my favourites of what Harvey talks about is what he called care tenor. That's quite a North American term. We would probably say the tone of care. And it's really the approach that we have and not what we say. And I really was struck by this when I was in Dundee, and I was over at daycare at the hospice in Dundee, and I was waiting to see a patient about a piece of research, and I was just checking what I was going to do with the man that day was talk to him about the research and see whether he wanted to participate in research. But the daycare sister at the hospice in Dundee had been an old student of mine, and she just got back from holiday, and she was making me a cup of coffee, and we were laughing. And I hadn't realised that the patient had arrived because he'd been at physio, had been arrived while we were talking. And then when I went to see him and I started introducing myself, he said, "No, I'm going to take part in your research." I said, "You haven't even introduced myself. I haven't told you anything about me." He said, "I saw you over there with Evelyn." And I thought, I like the look of her. I like how she is. I like her approach. I'll do anything that she says. So having a laugh with a cup of coffee made the patient want to participate in my study. What Harvey always said with his dignity model, and this is actually one of Harvey's slides, is that he saw the dignity model having both clinical approaches, but also dignity-specific interventions. And it was the dignity-specific interventions that I was most interested in. And I have really since, for about the last 10 years, developed and done research in 3 different interventions that come from Harvey's model. The one that we've developed the most, and this is the one that was born really out of my time with Harvey when we were there in Winnipeg, was what we've called the dignity care pathway, now called the dignity care intervention, which is an intervention for community nurses to help them give more person-centred end-of-life care. Dignity therapy I'm not talking about today, but that's one of Harvey's inventions, if you like, comes from the model. And I've done work on dignity therapy with people with dementia in Scotland. And I will talk briefly about the work that we've done around the patient dignity question. So our dignity care pathway study. So this is an intervention that we have worked on for a good number of years now, working very, very closely with patients, with family members, and with community nurses to help them give more focused care to people who would want to die at home. So we've always seen that this intervention has more than one part. We have a manual. The nurse asks people about their key concerns to find out what is their key concern from their viewpoint. We've designed reflective questions and then evidence-based care actions to help the nurse give more focused evidence-based care. We always saw this as a circle of care. So the nurse assesses using the patient dignity inventory. They identify the sources of distress from the patient and they work out how to address them with both the reflective care and the care actions. They use the care actions with the patient in partnership with the patient, and then they evaluate again. So our patient dignity inventory was already developed by Harvey. So I didn't invent the PDI. We slightly adapted it for our work in Scotland. But this was already something that Harvey had developed. So we decided that this was the best way of the nurse assessing the person's key concern from their viewpoint. And in our studies, we ask the patient to rate each of these 26 key concerns from 1, not a problem, through to 5, an overwhelming problem. And what I say to the nurses in my research related to this is that if the patient says it's 3 or more, then you have to deal with it. So the actual inventory looks something that's the actual intervention looks something like this. So the patient's key concern on the left-hand side in the middle is some of our suggested reflective questions, and then our care actions. And our care actions come from evidence. So they come from a systematic review of the literature. They come from focus groups that we've done with patients, with family members, and with both general practitioners and community nurses. But they also come from what we know already, evidence-based guidelines out there. And what I was really, really keen on, and with the other people that I've worked on, is that every single care action is in the repertoire of the nurse. So they can't do what we nurses do. What we're famous for is referring on to other people. We know about this work, so our evidence from our work has shown that my intervention recognises and records the community nurse contribution to end-of-life care. It confirms the evidence base, validating some of the comfort activities, and that we find that nurses are able to identify the dignity-related concerns from the patient's viewpoint, and that they are able to target their care based on what the patient says. Probably in terms of the interventions that I've developed and tested, we've gone the furthest with this one. We have done work in the West Highlands, specifically Oban and the surrounding islands. We did work in Tayside, across both Dundee, Perth and Angus. We've done work in England, specifically in Nottingham and Nottinghamshire. We have done a study funded by the Irish Hospice Foundation across the whole of Ireland. That was a 2-year study. We've recently completed a systematic review for looking for outcome measures to be able to test the intervention. And we also have DCI Sweden now. And my Swedish colleague Ulrika Ostlund was just been over with us in Scotland and unfortunately couldn't stay today. And she's now given me the Swedish version, which I'm afraid I don't understand. But she assures me she did try and translate it for me. We now have a PhD. So my intervention has been translated into Swedish, and we now have a PhD student at Uppsala University implementing the DCI in Sweden. We want to get money to use implementation science to implement the DCI across Europe. Easier said than done to get European funding now. We've got colleagues in Spain as well who are really keen to work with us. On to mentor number 4. It's my only mentor who's here in the audience today. Professor Jane Seymour. So Jane is now a professor at the University of Sheffield, was a professor leading one of the only nurse-led palliative care teams in the world, actually, in Nottingham. Jane encouraged me to apply for the job, and I did think very carefully about applying for the job as a professor in Nottingham because my children were right in the middle of a crucial time at school, and Craig didn't particularly want to move. So I wasn't going to apply, and then I decided that I wouldn't ever get a better opportunity to work with somebody like Jane. So I applied for the job as Professor of Palliative Care at the University of Nottingham, and was delighted to be chosen and worked with Jane in Nottingham. Learned so much from Jane, so much, particularly about how you lead a team, about how to do different areas of palliative care research. Some of Jane's, there's a lot of parallels between our work. There's a lot of Jane's work that has been quite different to the work that I've done. But also, primarily I learnt from Jane about capacity building, and particularly capacity building in the form of PhD students. Jane had a fantastic record of PhD students coming from all over the world, but particularly sub-Saharan Africa. So she taught me how to manage challenging situations sometimes, but Jane's been fantastic at capacity building in palliative care. These pictures, Jane won the International Nurse of the Year when I was editor of the International Journal of Palliative Nursing. So it was fantastic to be there when Jane got that award. And Jane's also a friend, and I wouldn't have coped with that mad commute to Nottingham without the friendship of Jane. We had some fantastic discussions and chats whilst I was there, and continue to be friends, and we will continue to work together. On to the role of carers. Just some brief statistics. It's really, really difficult to get statistics for the number of people who are caring for people at the end of life across the UK, partly because so much of caring is hidden caring, and people don't necessarily identify themselves as a carer. The Scottish Government stats estimate that there are 788,000 people in Scotland who are caring for a relative, friend or neighbour. And they say that that's 44,000 who are under the age of 18. 44,000 just in Scotland who are under the age of 18 caring for people. We do have a new Carers Scotland Act, which takes effect next year. And the legislation should help ensure better and more consistent approach for adult carers and also young carers. But that does mean that people have to identify themselves as carers. Actually, we do know that actually the role of carers, particularly looking after people who are dying, is that most people are unprepared for the role and the challenges that they will face as carers. Jane's recently published a study where, using an exciting research method, worked alongside family carers and volunteers to design a training programme where the role of the training programme is to support family carers who are looking after somebody. We do a lot about training health professionals and training our unregistered staff. We do very, very little training for family carers who are looking after people. Mostly people just have to do it and don't get any preparation for this role. This is data from a student who I supervised when I was at the University of Nottingham. Claire Smith was awarded an award that we don't have a similar type of in Scotland. It was called a Health Education East Midlands Bronze Award, and it was about preparing nurses and allied health professionals who wanted to go on and do further research. Claire talked to bereaved carers, and this is interesting. So this is very recent data. This is the bereaved daughter who she spoke to in Nottingham. On one occasion, where my father had said to me that he was feeling cold, and I asked for a blanket. I asked her for the blanket, the nurse. The nurse rolled her eye, sighed, and said, well, when I get a chance, I'll go and get him one. I had to ask her a second time, and in the end, when I had to ask her a third time, it was a different member of staff. If I could have gone and found the blanket myself, I just didn't know where the cupboard was. And I thought, well, if they're not even bothered about him being cold, what else are they not bothered about? And every time I left, I just felt so bad for leaving him, just in case he didn't feel like, just in case, he didn't feel like he was being looked after. Nurses, the small things matter the most. Just some data from my postdoc around carer support. This is from a lady who I've called Adele. So this is in my postdoc, I triangulated the data. So I interviewed each patient who had advanced cancer twice. I asked the patient who in their friends or family had given them the most support at this time of their illness. And when they told me, I got the person's permission to interview that member, that person, that friend or family member. I also said, which healthcare professional has given you the most support? And with the person's permission, I interviewed that person. So you'll get an example of how you triangulate data. So this is interview 1 with this lady. I'm still enjoying myself. I'm still doing things. It's not very good for the family to have a waiting to die attitude, because obviously they worry about it and it. So we had a bit of a conversation, but then I'm asking her, so tell me about the family. My son, I'm 67, he's my son. He's a hairdresser, married with 2 children. My daughter's 37 and she's got 4 boys. My younger daughter has no children, but she's married and she's 34. And then I say to her, now I'm going to ask you a difficult question. Who do you think's given you the most support in recent times? And she says, the daughter with the 4 children, because she worries the most. She will take this very badly. It will affect her very, very badly. So she is coping with an advanced illness herself, and she's worrying about her daughter. And I say to her the next time I see her, it's usually about 2 to 4 weeks apart, because these people who were seriously ill that I was visiting, and I visited people all over on purpose. I data collected across the Highlands of Scotland, because I was interested in people who were far from a hospice and far from a cancer centre. So I say to her, this lady lived about 80 miles north of Inverness. So I said, so we talked about your managing and your experience of your illness and the things that were important to you, and see if I'm right in remembering family, trying to keep as independent as possible and living day to day and very much keeping living, and your faith. Have I got them in the right order? Family, faith and independence. Family came first with this lady. So this is when I talk to her daughter. She tells me, I feel I'm constantly quite stressed. I mean, yes, I do worry. I worry because you get frustrated because you can't be there all the time. And I think that's the big problem, is the fact that as much as I do go over quite often, you can't be there all the time. And she'll phone up and she'll say she's been sat in her pajamas all day and she just couldn't physically get her clothes on. And I say, why didn't you phone me? And she'll say, you were doing such and such and you just felt terrible. Always personally feeling I'm not doing enough. And yet I know I do more than my brother and my sister. A bit of sibling rivalry in terms of caring as well. And this is when I talk to the health professional. And she says she gets a lot of support from the family. And then I'm saying, but she also supports her family. And then the health professional says, yes, she's the linchpin within the family. I think the balance is changing slightly with her diagnosis of liver cancer and her stressors within the family, within some of the relationships. She had quite a turmoil, I think, to shift the balance. I don't want to use the word power, but she was the strong woman in the family and protecting the family, and it took a lot for her to start passing information on and seeking active help from them. This lady didn't want to tell the family how bad she was getting. Many people would argue that caring is a feminist issue. I'm actually going to talk about Tommy Whitelaw. I think Tommy was here. Here. And Tommy, his Glaswegian, who's cared for his own mother with dementia. And now Tommy has talked about his experience of caring for his mother all over Scotland. He now has a charity called Dementia Carer Voices. And when he goes and talks to people involved in caring for people with dementia, and many of them are nurses, he asks them to make a pledge. And Tommy has now thousands and thousands, I think the latest count was 90,000 pledges from people. And some of the work that we're going to do, that we're actually seeking money for, is to work with Tommy on looking at those pledges and looking at the impact that can happen from looking at the theme of those pledges. We want to look at making the pledges make a difference, if you like. Caring starts both before and after the person's died. This is from Raymond Briggs. People will know Raymond Briggs from The Snowman, but he wrote this brilliant cartoon biography of his own parents, Ethel and Ernest. When I showed my children this, they thought it was a bit too macabre, but actually it's very relevant for nurses' role in end-of-life care, because on the left-hand side, it's when they're getting, the son is telling the father that the mother has died. And then you see her laid out on a trolley, and the son saying to the father, "Why is she on a trolley?" And he's saying, "I don't know." And then the son's saying, "Bloody Kleenex and Vim right up her face." And then, "Why?" And then he's saying, "I don't know. I don't know." Actually, I remember Vim. So I remember our mother had Vim, or is in the house. So I think it's one of those cleaning products. You need to be born at a certain time to understand Vim. But just so important, even that last stage when somebody dies. And it's absolutely a fundamental role of the nurse. Nurses are really the only people who are there actually at the time of death and help lay out the body when somebody dies in hospital. Just briefly about some of our future work, because most of this story is about going backwards. And we have just started a PhD studentship, Maria's in the audience, where we're going to be developing a carers intervention for people who are caring for people with life-limiting conditions here in Glasgow. So watch this space, because Maria's just literally started 3 weeks ago. But the innovative thing about this studentship is that we have funded a nurse at salary level rather than a traditional PhD stipend. So what Mags and I are trying to do with this particular studentship is to grow what we're calling a clinical academic career. You're not a clinical academic till you've done your PhD, but in terms of growing the future clinical academics, we want the person to be studying their PhD, but remaining in practice. So Maria remains 1 day a week in practice as a district nurse. The patient, the most important person in end-of-life care. My sister's a photographer. This is a photograph from a fairly well-known photographer called Claire Park. Claire was a ballet dancer with the Royal Ballet, then a Vogue model, and is now a photographer. And she won an award, I think it's called the Associated Press Photography Award. And I discovered this photograph in the Sunday Times magazine. Claire took this of her own mother just before she died. And I think it's a really powerful, and I think a very beautiful photograph. But we don't see death very often. Nurses do, but rarely do other people. So I really wanted to show this photograph. I have talked to Claire about some of whether she's done other sort of work like this, but this was just a particular thing that she wanted to do. And as I say, she's won an award for this photograph. When we speak to people, what do they worry about the most when they're coming to the end of life? Top in this particular survey, published a couple of years ago, was to have pain and symptoms well controlled. So that was number one. But number two, thinking about Adele, who I spoke to in my own research, to not be a burden to my family. Do we do anything about that in healthcare today? Those people here who work in palliative care, do you actually consider that and actually do anything about that? That the number two in this particular survey of of 1,000 patients is not being a burden to my family. I'm particularly interested in the concept of personhood and person-centred care when we're thinking about the patient in end-of-life care. Personhood is about a standing or status bestowed on a human being by others in the context of relationship and human being. It implies recognition, respect and trust, and it's part of person-centred care. Person-centred care is about seeing patients as equal partners in planning, developing and assessing care. Do we actually do this in end-of-life care? I wonder whether we really do this enough. I think we do, but I don't think we actually do. We do know that person-centred care is in the rhetoric, often of policy, that it's part of good healthcare practice and encompasses a holistic, personalised ethos. And I would argue that it's part of conserving the dignity of the dying person. What we should be doing as health professionals is taking the lens of the person, actually thinking about how they view the world. Harvey talks about dignity being in the eye of the beholder. And I think if we really stepped into the patient's shoes, then we might actually give better end-of-life care. Dignity is so important in healthcare. We know it's encouraged in all aspects of healthcare. It's welcomed by people facing end of life in terms of preserving and conserving dignity. It's actually often the loss of dignity is what people fear the most. They fear that more than being in pain and having distressing symptoms. It is on the government agenda, but it's often a subjective term, and we don't really think about what it really means. We've done research, this was research that I did in Dundee, looking at Harvey's patient dignity question. So Harvey's patient dignity question, which is another intervention that he developed from his model of dignity, is what do I need to know about you as a person to give you the best care possible? And how simple does that seem? But we really don't always do that. We're the first people, we've just done a pilot study, but we're the first people to have tested that intervention in a research context in the UK. And we published our study about 3 years ago now. So just a little bit about what we did in our pilot study. We were looking at whether when we asked that question, my hypothesis was that if we asked that question to people in the hospital setting with palliative care needs, so people who all had life-limiting illnesses, who are likely to be in the last year of life, if we asked them that question, we could improve their person-centred care. So we used an outcome measure called the Person-Centred Climate Questionnaire. We also used another outcome measure called the Care Measure to see whether, if we asked this question, we can improve the empathy of the health professional. We also used a feedback questionnaire that Harvey had already designed, both for patients, their family members, and for health professionals. We also interviewed some of the patients we spoke to ask them more about whether they thought this was a good idea and how it felt them being asked this question. So just some brief insight into some of our findings. Most people felt that us asking this question, recording what we did was we asked the people the question, we recorded that, we wrote it up on a piece of paper, we then typed that up, we then checked with the patient that our summary was correct. We said no more than half a page in terms of summary, the patient's summary was no more than a paragraph. And then we displayed that summary in the nursing notes and the medical notes. In Dundee at the time, we had separate nursing notes and medical notes. The majority of the health professionals agreed or strongly agreed with our items on our questionnaire. Just a bit about the patient's perspectives. I appreciate the whole team. People try, they can't do enough for you. And just interestingly, that the theme from our interviews was knowing me as a person. And that was a theme way back in my PhD all those years ago. And this patient was saying, do you know, I'm not just a person with cancer. I have a family. I have a life. And I would argue that's absolutely our role as health professionals, to understand that and respond to that. And this patient, lack of communication is a big thing for me. Nobody comes across and speaks to you. The patients, the majority of them felt that the summary that we'd written was accurate. They agreed that it could be displayed in their notes. They didn't always want a copy, which was interesting. The majority of them, 83%, believed that the information would be important for the health professional. And about 2/3 thought that it would affect the way the health professional in the future gave their care. And the health professional, we mean the nurse, the doctor, and the allied health professionals like physios, OTs, and other people working in the hospital setting. And the majority of them would recommend it to others. Health professionals, interestingly, most of them felt that they did learn something new, even in areas where they knew their patients pretty well. Some were emotionally affected by reading it, and many of them felt that it influenced their attitude and their care and their respect and their empathy. Just a little bit of data from the health professionals. I've tried to keep the PDQ summary in mind when I'm speaking to the patient. Good. And then another one, the PDQ allows the staff to get a bit of insight into the patient. It's not always obvious when we first meet the patient. Remember, this is a simple question. What do I need to know about you as a person to give you the best care possible? So what we found from our pilot study, that our PDQ has potential to improve the patient's perceptions of care, as well as the health professional attitudes. We found it was well received by participants, that it can provide information that may not be available through routine processes and procedures that normally would happen, despite the fact, as nurses, we supposed to do a fairly detailed assessment. And same with the medics, also do a detailed clinical assessment. We still found that the health professionals who responded to our questionnaire were mainly junior doctors and nurses on the ward. We felt also from our pilot study that it could be incorporated into routine practice. But we did find out, and not surprisingly, this was a small pilot study with 30 patients, that we should be doing a bigger study. And we are actually currently looking for money to do that, and we will be doing both an efficacy trial and implementation trial. The efficacy trial here in Glasgow, across our Glasgow hospitals, and an implementation trial across the UK. We're hoping to put in a grant for that at the end of this year. This is going back to my postdoc data around self-care and advanced cancer. And the most important theme that we found, I did 71 interviews in my postdoc. And more than anything, the theme that came through was what we've called, and there is other literature absolutely to endorse this, maintaining normality. What my colleague and friend Harvey called maintaining normalcy. I think that's an American term. This is a lady in my research I called Harper. So this is me, the first interview with Harper. So she says to me, I thought to take chemotherapy now and at this minute when I'm feeling good, and I was feeling fine. I wasn't ill. I was doing work at normal business, normal, just everyday things normally. And I thought, now, why should I volunteer to be sick? Because that's the way I looked at it. And I said to him, that's the consultant oncologist, I says, that's the way I see it. I say, I'm not volunteering to be sick. I said, there's no guarantee at the end of it. I said, for how much time? There's no guarantees in this. And then the next time I see Harper, she was really very sick, and she'd chosen the only treatment she would agree to was going to daycare at the hospice, which is how I first met her. She wouldn't agree to it. She went to every single consultant appointment, but she just wouldn't agree to any treatment. I really liked her. And then when I go back to see her, and I said, and you said to me, when you're feeling really bad, you would still go to the shops, but you would get the taxi back again. I could see Tesco's from Harper's house. And she says, well, I've seen me go some weeks, and I've been too tired, and I haven't been able to manage to the shops. So I've run sort of low. So what I would do is I'd make my way to Tesco's, and I'd overload with enough to do me, maybe a couple of weeks. And because I was so overloaded, I could get the taxi home, because she couldn't physically walk to Tesco's. The Tesco's in the area where she lived were really kind to her, and they would help her go round the shop, but they didn't. She still had to get home. I really wanted to do her shopping for her. That took everything in me, not to say, well, I'll just go to Tesco's for you. I really think that was the role of researcher. And this is me talking to her daughter. Now her daughter, so she lived north of Glasgow, and her daughter lived in the south of England. And I said to her, and I'm saying to her daughter, I didn't go all the way to the south of England. My research budget didn't actually run to that. We did this by telephone. So I say to her, do you think that's part of one of the things that strikes me is your mum's managed her illness by, kind of normality. Would you agree with that? And the daughter says, I would agree with that, definitely. Yeah, she's carried on pretty much the same as before. She didn't stop doing any of the things that she did. And for my mum, part of the going to the hospital and having these little sort of, not arguments with the doctor, but these discussions, she likes that. It's a control thing. Also, out of data from this same study, a theme that we called preparing for death. This is really interesting. I didn't say to any person that I spoke to, are you preparing for death? I was asking them how they were managing their illness. And every single person I spoke to, the youngest person I spoke to was 35, the oldest 93, they all volunteered to talk to me about their end of life. And this is from a carer, a daughter. When my mum eventually does die, it's really important to me that we should do what she wants and we get it right for her. So we've spoken about, is she getting cremated or buried, types of hymns to be sung at her funeral. And that's important I do that because I'll not get another chance to do anything for my mum again. And this is another patient. This is one of the oldest people I saw north of Fort William. And he says to me, I've told my GP I'd rather die in my own home. I don't want to die in. I'm not dying in, and he names the care home. That's the local dying factory. I don't think dying is an event. I think it's a process. I think you begin to die when you feel you've lost the world that you're in. You've lost the world that made you, that you're brought up in. There's still plenty of things that interest me, but I do it alone now. And this is another person I saw. This guy was north of Glasgow in his own home. His wife was there when I saw him. And he says to me, I've got a lot weaker since I last saw you, and I seem to be going all detached. I'm getting worse. I'm trying to keep in with everything because I endeavour to get washed, shaved and dressed every day. And I wonder whether the health professionals had spoken to this guy about his end of life when he absolutely knew he was dying. This is data from our dignity care intervention interviews and how much people worry about how their family will cope. And this particular lady says, I've put things into place. And there were some of the things, and particularly when I did score on our intervention, was the concerns for my family after I'm gone. Do we actually do anything as nurses about this? And finally, back to being a Florence Nightingale Foundation professor. So this is me with some of our Florence Nightingale colleagues. Ursula will remember this well because that was our Florence Nightingale Foundation service in Westminster Abbey this May. The Florence Nightingale Foundation has a service in Westminster Abbey every year. And so back to the unique role that I have that is both here as a university professor, but also as a clinical professor in the NHS. And I think perhaps, as we talk about building capacity, we think more about academics actually supporting people in practice. If you go to a hospital today in Glasgow, any of you, and whether you have a life-threatening condition or not, if you're staying in hospital for several days, I can guarantee that you'll meet a senior doctor. You might even meet a professor from the University of Glasgow, but you will not meet, or highly unlikely to meet, a senior nurse. And that's a fallacy, really. The most senior nurse you may meet, even if you're in hospital for a week, will be somebody who's really quite junior, what we would say is a band 5 staff nurse. You might meet the ward sister or the charge nurse, but you might not, because they'll be in the office. And I think we need to do much, much more so that patients get the excellent care that they should get from senior nurses as well as senior doctors. I mean, in Scotland now, brand new, I think they're coming out in the next couple of weeks, we're going to have a uniform that's particularly for senior nurses. So I'm going to get my smoked berry uniform. So watch out for smoked berry, everybody. And this is for anybody who's in a nurse management, senior nurse management role or above. And so that if you're in a patient in Glasgow, really from, I suppose, December onwards, watch out for the nurses in smoked berry because they actually will be senior nurses. So that's one of the things that I think that we do need to change in terms of building capacity for the future, but also changing care of people who are dying wherever they're dying, in Scotland in particular. I think I've spoken enough now. So I'm going to hand over to my esteemed colleague, Professor David Clarke, who is going to speak.